Hello and welcome to the Alabama Public Health Training Network. Thank you for joining us today for our program, Alabama's Serious Infectious Disease Network. If you have a question about anything being discussed today, please call or email during our broadcast. The phone number and email address are on your screen now and will appear again later in the program. Also, the handouts and sign-in sheet and evaluation are all available online. You will need to register for this program in order to access those materials. Continuing education credits have been approved for nurses and social workers for today's program. In order to receive credit for this training, you must watch the entire program, then complete and return the sign-in sheet and evaluation. While content may continue to be relevant, continuing education credit will be awarded 1 year for nurses expiring on August 31st, 2018, and 2 years for social workers expiring on August 31st, 2019. I'm Dr. Karen Landers, Assistant State Health Officer for Public Health Area 1, and I would like to welcome our presenters today. Dr. Scott Harris, Assistant State Health Officer for Public Health Area 2, and Dr. Sarah Nastasiger, Assistant State Health Officer for EMS Director. Welcome to both of you.
Thank you. All right. Thank you very much. We appreciate everyone joining us this afternoon. We're very glad to have you here on our broadcast today. We're very excited to bring you some information about Alabama's Serious Infectious Disease Network that's being rolled out at this time, and we have a lot of ground to cover today. First of all, you'll see we have our requisite CDC disclaimer, and I'm not going to read that for you today, but we'll have that in case you want to refer to that later. The objectives that we want to cover today are we want to define the purpose of Alabama's Serious Infectious Disease Network. We want to discuss the SID network tiered approach response for each provider. We'd like to discuss the SID network screening tools for use by EMS providers. And we'll discuss the functions of unique operations that are specific to suspect patients or persons under investigation for a serious infectious disease. So what is the SID network? The Serious Infectious Disease Network is just a network of facilities within Alabama. It includes different healthcare facilities and uses a tiered approach to identify patients who might be presenting with a serious infectious disease or a disease of concern for some reason, for public health concern, or because the disease might be highly infectious or potentially so. We use the SID network with diseases that require very intense clinical management or specialized clinical management, diseases that might have to be cared for in multiple institutions depending on where a patient might first present as compared with where they may ultimately end up for care. The SID network was originally developed around the idea of Ebola. If you remember when the Ebola outbreak in West Africa began in 2014, there was a lot of anxiety and a lot of uncertainty about how we would deal with those patients when they came to our country. And that's really sort of set the stage for planning the SID network. But really the SID network is much more than that. It's really a planning process that continues to develop and that is ongoing and allows us to adapt to other public health problems that may show up, to emerging pathogens, to certain serious infections that we have occasionally worried about, if not actually seen, such as SARS or smallpox. And so it really gives us a framework for being able to sort of quickly and nimbly deal with these issues as they arise. It was originally designed around Ebola, but it's going to be so much more useful for many other things. So the topics that we're going to cover today are listed on your slide. We're going to begin just with a brief overview of the previous Ebola outbreak, as that is what really put all of this into motion. And then we'll talk about the different facilities or different tiers of facilities that are a part of the network, including our frontline healthcare facilities, our assessment facilities, the treatment centers, and then we'll have a piece on emergency medical services and how those providers deal with the SID network and how they fit into that overall plan. And finally, we'll discuss some other infectious diseases of concern for which the SID network may be applicable. So just as a reminder, the seeds for this were all sown back in about 2014 when an Ebola outbreak was first recognized in West Africa. In March 2014 is when the outbreak was officially declared, although the index case in that outbreak probably occurred a few months earlier, and in fact, epidemiologists studying that have looked back and really identified an index case. They've identified a child who died in Guinea, probably in late 2013 or maybe early 2014, that served as the single index case that set this entire thing into motion. Within a few weeks, the outbreak began to involve countries that were contiguous to Guinea, including Sierra Leone and Liberia, as well as other cases in West Africa. And it reached such a scale that the United States and many other countries began to implement travel advisories and screening of international travelers over concern that an incubating infection could arrive on a plane, really within 24 hours from anywhere in the world. This is just a map to remind you of your geography. Sierra Leone was in Liberia were the second and third countries to get infected, but you can see how they're contiguous with Guinea. And actually within just a couple of months, we began to see infections that showed up in other countries that were not contiguous, including Nigeria, for example, and other places in Africa, as people travel by air or even sometimes by road to more remote places, but with incubating disease. The outbreak really took over 2 years before it finally abated. These are case counts that were summarized at the end of April 2016, but these are actually the most recent counts because that was actually the time in which the outbreak was declared generally over. There were over 28,000 total cases of Ebola that developed out of that outbreak. Those include not just confirmed cases, but suspected and probable cases too, based on the case definition. But about 15,000 of those cases were actually laboratory confirmed, and that led to over 11,000 deaths, which is a mortality rate of over 40%. Now, if you remember what happened in the United States, in August of 2014, the first American Ebola patient was flown back to the U.S. Now, this was a healthcare worker who had been working with Ebola patients in West Africa. This person became ill and was brought back to the United States, and that was the first case that was knowingly brought back. On purpose, of course. But in September of 2014, in the fall of that year, the first case was confirmed in a patient who traveled who was not known to be here. And this was a Liberian gentleman who was located in Texas. You may remember that story. This was a person who had become ill after returning from West Africa. He had helped to care for a person who had died from Ebola and had participated in a funeral for that person. He returned to Dallas, Texas. Within a few days had become ill with fever and actually had an emergency room visit. And no diagnosis was made. He was returned home. He eventually came back to the same hospital a few days later and was diagnosed with Ebola virus disease. This turned out to be a really difficult situation for that hospital in Dallas, as you may remember. There were actually 2 critical care nurses who cared for this patient who subsequently became infected themselves. They had to be taken to Ebola treatment centers in other parts of the country, and fortunately both of those individuals did well. But the hospital, seeing the very first case like that, really had to face some very difficult issues. As you might imagine, there were no elective surgical procedures performed in that hospital at all. The public stayed away in droves. People were not willing to be admitted to that hospital over concern about this particular case. And so it was a difficult situation for what's really a very fine hospital, a very fine institution in that city. But it really highlighted the difficulty with taking care of these very complicated patients and trying to make sure that infection control risks are minimized, that patients are still taken care of, and that patients are able to get to the locations where they need to go to get adequate treatment. One additional fact you may recall is that a couple of months later, a returned traveler was diagnosed in New York. This was a healthcare worker who returned home, not symptomatic, but developed symptoms after returning home. This person was not known to have infected anyone else and ultimately did well. But it certainly, again, just goes to highlight the problems you can see with a disease of this severity that can be transmitted in this way. And just as a reminder, Ebola still continues to be an issue for us. This particular outbreak, is considered over. But as recently as May of this year, there was a mini outbreak or smaller outbreak in the Democratic Republic of Congo in Central Africa, which included 3 deaths and 6 other infections that fortunately survived. So this is still a problem that's on the radar. We don't have active travel screenings going on in the way that we did at that time, but it's certainly something that we can't afford to forget about. So in the wake of all that, ASPR, or the Assistant Secretary for Preparedness and Response, made available the funding opportunity to the states. Not exactly a mandate, but funding and suggestions that we begin to develop a network for dealing with this particular problem. ASPR, the Hospital Preparedness Program, as envisioned by ASPR, recognizes the need to ensure that we're prepared to respond to Ebola patients or patients with any type of serious infectious disease, and then also provided funding to ensure, as they say, hospitals are ready to safely and successfully identify, isolate, assess, transport, and treat patients with Ebola or patients under investigation for Ebola. And in preparing for this, we feel like all institutions will be better prepared to deal with any type of emerging infectious disease or highly contagious pathogen. So we proceeded with the idea to establish a network of facilities within Alabama that would be able to deal with this. We have, as you'll see, a tiered approach, which involves frontline facilities, assessment facilities, and then treatment facilities as well. Again, I want to reemphasize that although this came out of the Ebola situation that happened in 2014, this is really a framework that lets us respond to any type of outbreak, and it's something that we're going to keep in place even when there's not known Ebola activity, because it allows us to be ready to respond to any type of highly infectious disease. A tiered response allows patients to be identified at whatever facility that they present to. Diseases of concern can be considered. Those frontline facilities can then coordinate appropriate response among local, state, and federal partners. And we can make sure a patient is able to get to the appropriate level of care as needed. So to begin with, the tiered approach includes so-called frontline healthcare facilities. And we'll spend a little bit more time talking about who is considered a frontline facility. The idea is that frontline facilities can identify a patient who might need to be investigated further. They can properly isolate that patient in order to protect healthcare workers and to protect the public. And then they can inform the appropriate folks, the appropriate public health authorities and other stakeholders who need to be aware of that. Assessment hospitals would typically be receiving those patients that were thought to have a serious infectious disease. The goal for those assessment hospitals is to test the patient to try to make an established diagnosis, hopefully within just a few days. And then if treatment is needed, to transfer that patient to the next tier, which is the treatment center. And the treatment center would actually be involved in the active treatment of the patient with a serious infectious disease. So what are frontline healthcare facilities? These are acute care hospitals or other type of emergency settings. These do not include routine ambulatory settings, but these are acute care hospitals, hospital emergency rooms, urgent care clinics, also critical access hospitals. Any of these acute care settings that might see a person presenting for care other than just routine outpatient or ambulatory settings. Again, as we mentioned, the goal of the frontline facility is to identify, isolate, and inform the patient. In terms of identify, what we mean is, first of all, identify what risk factors the patient has. We want to identify if the patient has, for example, a travel history that would be pertinent. Is the patient coming from a place in the world where there's an ongoing outbreak with a serious infectious disease or some type of pathogen? We also want to identify what the symptoms are that patient has. Does the patient have an illness that's clinically compatible with, for example, Ebola or some other type of infectious disease? So identification is the key step that really puts all of this in motion. We want to know where the patient has been or who they've been in contact with and what type of symptoms that they have. The second tip then is to isolate the patient if that's considered to be appropriate. In terms of isolation, again, that's done to protect the community, but also to protect our healthcare workers as well. The facility needs to help determine what type of PPE is needed, how much of it is needed. We would typically think that frontline hospitals would want to have personal protective equipment for around 12 to 24 hours of care. That would presumably be multiple healthcare workers and multiple shifts over 12 to 24 hours. So we would want to make sure that there's enough in place. And the vision is that that would be adequate time for the frontline facility to identify what's going on with the patient, or if the patient needs additional investigation, and then set the SID network into motion. The information, or the informing piece for frontline hospitals, is to notify hospital infection control or other infection control folks that work with the facility, and then appropriate staff who's going to be taking care of the person in that facility, and then to notify the health department as well. We've included a phone number here on the slide, and you'll see this several times throughout the presentation. Certainly the health department would like to be notified immediately if there's some concern on the part of a frontline facility that you have a patient who needs further investigation or is of concern because of potential exposure. So, just to summarize, the frontline facility is going to have the first contact with a patient typically. A patient may present there requesting help or having certain types of symptoms. The frontline facility is going to treat this patient like any other patient initially. You conduct an initial health assessment. You try to recognize and identify symptoms of a serious infectious disease, and then provide care to that patient for the next 12 to 24 hours, including appropriate use of personal protective equipment until a disposition can be made as to what to do with the patient. This really sets the tone for an effective response. The role of the frontline hospitals is really crucial. It allows everything to be put into motion and resources to be utilized appropriately and effectively. It allows public health to get involved as early as possible and be aware of the situation and help to coordinate that among the other stakeholders. And here's the phone number for you again in case you missed it on the previous slide. Finally, remember that frontline facilities do need to continue to be concerned about not just patient care, but also worker safety. So isolation protocols are very important, and infection prevention and control protocols also need to be followed. So after a patient has been seen in a frontline facility, they may then subsequently be transferred to an assessment facility. We actually have 3 assessment hospitals in our state that we'll talk a little bit more about in just a few minutes. Assessment hospitals are institutions that have elected to participate in an evaluation to be determined that they can be assessment hospitals. They have been designated by our state health officer after a rigorous review of their policies and procedures and resources and abilities to take care of these problems. These are hospitals that will receive the patient, who can care for them while the diagnosis is being established. They can isolate the patient appropriately, and they can give immediate evaluation and coordination of testing to make sure a diagnosis can be established. We typically would think that an assessment hospital might be able to have a patient with a confirmed diagnosis or ruled out within up to a 5-day period. This might be for Ebola or might be for some other type of infectious disease. But for that reason, we would expect them to have personal protective equipment that on hand to cover at least 5 days of care. And again, this would be multiple healthcare workers working multiple shifts for at least 5 days. If testing confirms that the patient has a serious disease that needs additional treatment, then the patient can be transferred to an Ebola treatment center or another treatment center, depending on the disease. The Ebola treatment centers that were initially set up during the Ebola outbreak are the ones who receive and isolate patients with confirmed Ebola virus disease that need additional treatment. They will care for the patient for the duration of the illness, however long that is. We typically would expect them to keep at least a week of Ebola personal protective equipment, and have the ability to restock that as needed, depending on how long a patient remains in the institution. And we would expect them to have a staffing plan to manage several weeks of care, as many of these illnesses may require very prolonged hospitalization. All right. So in mentioning our tiered approach, you see the list here, the institutions that are designated in each category. Our frontline health facilities are going to be most of the facilities in our state. So these are going to be acute care hospitals, critical access hospitals, urgent cares, settings, emergency departments, other places that might encounter these patients. And these are typically frontline healthcare facilities. We do have 3 assessment hospitals in the state who were evaluated, as mentioned earlier. We have the University of Alabama at Birmingham, we have Huntsville Hospital, and we have the University of South Alabama in Mobile. These institutions really do deserve kudos for being willing to do this. They accepted the responsibility as part of their duty to our state to stand up for this and to go through a lot of work and a lot of investigation, a lot of coordination and planning, and they've done a terrific job, and we're able to be designated as assessment hospitals by our state health officer. So we certainly appreciate all the efforts that they've put into this, and we're very fortunate to have these 3 institutions in our state to serve us in that role. The Ebola Treatment Center for our region is located in Atlanta. It's not in our state. It's located at Emory Hospital. At the height of the Ebola outbreak, there were actually about 55 Ebola treatment centers that were stood up nationwide. At one time, it was thought that there may be one in every state, but ultimately it was determined that additional ones were probably not necessary and that regional treatment centers could be used. So the treatment center in the case of Ebola for our state would actually be Emory Hospital in Atlanta. Now I'm going to pass the mic over to Dr. Sarah Nafziger, who's going to talk about considerations for EMS.
Well, thank you very much. So when we think about EMS screening, a lot of us think about EMS as when the ambulance shows up, but EMS actually starts before that with our public safety answering points. And those are our 911 dispatchers that we think of. So we really hope that the screening for Ebola or other serious infectious diseases happens with those folks answering the phone at our dispatch centers, and that they're asking questions and trying to identify when these patients might be at risk for Ebola. So definitely our screening starts there, hopefully, so that our EMS providers have a little bit of information before they arrive on the scene with a patient who might have been exposed to Ebola. So when we think about patients that we're worried about, these are the things that we consider: patients who have Ebola-like symptoms, fever, headache, weakness, muscle pain, vomiting, diarrhea, abdominal pain, or unexplained hemorrhage. Now, if you're like me, you're thinking, well, I've seen a lot of patients like that this week, Dr. Nafziger, so that doesn't really narrow it down very much. These symptoms are pretty vague. But when you have a patient like this and you pair that with the proper travel history, that's where we get concerned. So that travel history is when they've traveled to a country with widespread Ebola transmission, or if they've been in contact with an individual with confirmed Ebola virus disease. Those are the patients that we're concerned about. And of course, we're talking about Ebola here, but this, I think, can be generalized to other serious infectious diseases that we'll cover later as well. But specifically, this plan was set up for Ebola. So when you do identify, either at the dispatch, the public safety answering point, or if the EMS provider is the first one to kind of put 2 and 2 together and put the patient presentation together with the proper history, that's the point where the EMS providers need to implement their Ebola plan and call the Alabama Trauma Communication Center. Well, why on earth would I call the Trauma Communication Center? This doesn't have anything to do with trauma. Well, the reason for that is because the Alabama Trauma Communication Center has a duty to connect you immediately to the ADPH Office of EMS Medical Directors. Currently, that is either Dr. Elwyn Crawford, who's the State EMS Medical Director, or myself as the Assistant State EMS Medical Director. And once they get us on the phone, then we can assist you in the risk stratification of these patients to help you figure out how to respond to these patients. What personal protective equipment do we need? What do we need to do with the patient? How do we transport them? Where do we need to take them? All of these things are things that we can help you figure out the answer to using current CDC guidance. Sometimes this is going to involve a phone call with the EMS provider and the physician. Sometimes we may want to talk to the patient as well. And certainly the EMS medical directors, we're going to be talking to other physicians at ADPH who are infectious disease specialists in helping us make these decisions. So definitely we want you to remember that first phone call to ATCC to call for help is vitally important. Now, I know a lot of folks think, well, I just don't want to bother them. I don't want to raise the alarm. I don't want to feel silly if this is nothing. But let me assure you right now that we want you to call us. And in the situation where you suspect Ebola, that's actually mandatory. And even if it's another serious infectious disease, we want you to call us. You're not bothering us. This is our job. This is what we do. And the reason is that we've learned from our recent experiences in 2014 with the Ebola outbreak that in many cases we're able to talk on the phone just from getting some history. We can determine that the patient may be at no identifiable risk and that no extra precautions are required. Or we may identify that this patient is at risk and we do need to take some precautions, and we can help coordinate what those next steps are to keep everyone as safe as possible and help us take care of the patients. So let's talk about specifically some of those patient care issues, specifically about isolation. One key principle involved in taking care of patients with serious infectious disease is keep them away from everyone as much as you can. We want to keep them separated from other individuals. So sometimes that may be putting them in the back of the ambulance and closing the door. Sometimes that may be at the scene, leaving them in a room with the door closed until we figure out what's going on with the patient. You just don't want to have any extra exposure that you can avoid. You want to avoid that. Along the same lines, you want to minimize the number of EMS providers that come in contact with the patient. So you want to use the minimum crew that you need to safely transport the patient. There's no need to expose any extra individuals if we don't have to do that. When you're moving the patient to and from the ambulance, you want to clear and secure pathways of travel so that we don't accidentally contaminate bystanders. We don't want any onlookers to get contaminated accidentally, so that's something to think about, is using your resources to have those pathways of travel cleared as you move the patient around. You don't want to have physical contact with the patient without donning the proper personal protective equipment, or PPE as we like to call it. Even if you've already been in a situation where you've accidentally already contacted the patient and then you figure out that they're at risk for Ebola, it's not too late to go don your personal protective equipment and still try to minimize those exposures. With Ebola, we do follow standard contact and droplet precautions. There are other diseases that might require further level of precautions, which is airborne precautions. But for Ebola specifically, since that's what we're talking about today, it's standard contact and droplet precautions. So when we're thinking about the transport of those patients, our plan really calls for them to be moved. From the frontline facilities, the patient may end up being moved to an assessment center. I'm not going to say it could never happen, because they could also be moved directly to a treatment facility. That certainly, you never say never, I think, in EMS, as we've all learned. But a person under investigation who we think has a high probability of having Ebola, or if they're severely ill, we're probably going to move those patients, and we're going to coordinate at ADPH where those patients go. And that's another reason for the phone call that I mentioned to ATCC. The earlier you involve ADPH, the better, so that we can help coordinate that care. When we talk about that coordination, we're going to be talking to a lot of folks on the phone. It'll be your state EMS medical directors. We're going to speak with the ADPH physicians, folks in infectious diseases, the Center for Emergency Preparedness at ADPH, and then in that public health areas, emergency preparedness region, we're going to talk to their coordinators. So we've got a lot of folks to coordinate with so that we can make sure we move that patient to the right place at the right time. After we do get approval to test a patient or move them and we decide where they're going to go, we will determine that destination for you in conjunction with the assessment hospitals, and we will determine the means of transport with you. It may be, there could be a case where we might actually let the patient be transported in their own private vehicle. They may need to be transported by EMS, and so we will help determine how that transportation happens. So that's another reason we need to be involved. We'll also help you determine the proper level of PPE to care for those patients. Our Center for Emergency Preparedness logistics folks and area EP coordinators will help us transport and help move that patient appropriately. So all these folks need to be involved to make sure that this runs smoothly, as we found from our experience in the 2014 outbreak. All right, I'm going to turn it back over to Dr. Harris, and he's going to talk about medical waste management.
Thank you, Dr. Nefflinger. I do just have a few items as we get towards the end of our talk that I just want to make sure that we cover and touch on. Medical waste management, of course, is an issue that's of some concern because of the potential infectious nature of waste. And what I just want to remind our facilities is that as long as waste has been properly inactivated or incinerated, it's not any longer a Category A substance, and so it's no longer infectious and can be disposed of in the way that other waste could be in that category. I provided some links to some very helpful sites here that you can see with EPA and CDC, and I would invite you to take a look at that. These are actually very good sites to give you information on how that's done appropriately. Medical waste generally is regulated by ADM, by the Alabama Department of Environmental Management. This is someone that we communicate and coordinate with as needed as well, and they maintain a list of permitted medical waste disposal companies. Finally, I did just want to include a few other special considerations for frontline facilities. Particularly for those facilities that may not be acute care hospitals. These may be some issues that you may not typically be dealing with in an urgent care facility, for example. Things like isolation, notification may not be the first thing that you consider, but those items, as well as having adequate personal protective equipment, are going to be very important. Remember to make considerations for waste management, as we mentioned a moment ago, and then you need to have some ideas in mind about transport from those facilities as well. Acute care hospitals are probably much more in tune with doing these things routinely. Other frontline facilities may not be, and so that's why we just want to make that point for our other frontline facilities. Okay. So let's talk a little bit more about other serious infectious diseases. You can see that kind of what we've wanted to present to you today is this framework that really grew out of Ebola, but could be used and generalized to a lot of other issues. So I want to talk about some other infectious diseases of concern, not that we've fully fleshed out a network for these individual diseases, but just to give you a flavor of the type of things that we're talking about for which this network may be utilized. The infectious diseases that we're referring to are ones that are highly contagious, that have a high mortality perhaps, or that just present sort of interesting challenges to infection control. They may have unique aspects that make them more difficult to provide adequate infection control within a healthcare setting. Many times these are serious illnesses that have intense and specialized clinical management. It certainly may be very prolonged clinical management, and or they may pose a significant public health threat. So, for example, viral hemorrhagic fevers like Ebola are perhaps the first thing that comes to mind, but there are certainly many other viral hemorrhagic fevers that cause similar type illnesses. With the degree to which people travel in the world now, we're really almost 24 hours away from any point in the world, and so we certainly may have the opportunity to, unfortunately, experience some of these other illnesses as well. We just mentioned, for example, Marburg virus, Lassa fever virus, Machupo virus. Those are just examples, but there are many, many other possible viruses that could present a similar problem as Ebola. A novel influenza A virus certainly could produce a pandemic that may produce a similar situation. MERS coronavirus, Middle East respiratory symptom, is a coronavirus for which there have been cases in the Middle East, and we certainly are vigilant to make sure we don't have an outbreak here in our country. Smallpox is something that remains on the radar screen. Smallpox was really declared free from the world in about 1990. The last cases occurred in the 1970s, but there are unknown laboratory reservoirs of smallpox. It's certainly been mentioned as a possible bioterrorism agent, and so we have to continue thinking about smallpox even in 2017, and that's certainly a great example of a disease for which our SID network would be prepared to respond to. SARS outbreaks have not occurred recently, but SARS continues to be a problem in some places, or there's always the threat of SARS, and we want to remember that, as well as other types of emerging pathogens, including things that we just simply have not identified yet. Emerging infectious diseases many times are travel related. They certainly could arise de novo in any part of the world or any part of our country, but typically we think of them as tropical diseases in many cases, and so they are often travel related. CDC keeps an up to the minute almost list of travel health notices that are available on their website, and I would encourage you to take a look at that, particularly when you're encountering a patient who may be presenting with a somewhat unusual travel history. That's the best way really to find out about what things are happening in other parts of the world. Dr. Nafsinger?
Yeah, along the same lines, I want to just try to reemphasize that we recommend that if you're screening a patient and they've had an unusual travel history and have unusual symptoms, we really want you contacting ADPH as early as possible. That in the EMS world, we have you call Alabama Trauma Communication Center. And then, of course, Frontline Hospitals, we don't mind if you call the Trauma Communication Center, but we prefer you to call the ADPH number. But that travel history is just so important. I think since the 2014 Ebola outbreak, everybody has realized that, and some of us may be getting a little weary of asking those same travel questions when we bring our patients in, but we should always be vigilant about that because it is so important. Remember, once again, those patients who have that travel history and those flu-like symptoms, fever, rash, unexplained hemorrhage, vomiting, diarrhea, cough, that might be a serious infectious disease, and so think about giving us a phone call when you encounter those patients with that travel history. Dr. Harris?
All right. Thank you. Just as a reminder, public health does have reportable illnesses that healthcare workers and facilities and laboratories are required to report to us. We have different levels of notification depending on the type of disease. We have some illnesses that are reportable within 4 hours and others within 24 hours. Remember, these are illnesses that you should be reporting to public health even as a presumptive diagnosis. You certainly don't have to wait for confirmation or laboratory testing to return, but if you have a presumptive diagnosis of these things, then we would certainly want to be notified about that. For example, on the slide you see viral hemorrhagic fevers. These are 4-hour reportable illnesses. So if you have even a presumptive diagnosis, we would ask that the health department be notified within 4 hours, as well as some of the other things that you see on the slide there. And once again, in case you haven't seen the phone number yet, I'm going to show you the phone number one more time. If you have immediate, extremely urgent infectious diseases or other illnesses of public health interest, those must be reported to the health department within 4 hours of diagnosis, of even presumptive diagnosis. And here's a telephone number that you can see on your screen, 1-800-338-8374. This is manned 24 hours a day, 7 days a week, and we would appreciate notification within that 4-hour window for these illnesses. And then again, just to remind you, the health department, ADPH, has several roles within the network, even though the network is comprised of our frontline facilities and our assessment centers, our treatment center, and our EMS providers. ADPH plays a big role in that, and we actually have several different areas in which we're involved. We have our area health departments out in different parts of the state, as well as the central office here. We have our infectious disease and outbreak section with our epidemiologists. We have the Center for Emergency Preparedness, and we have our Bureau of Clinical Laboratories. So there's several hats that are being worn here by the health department in order to fully flesh out our SID network. And finally, I just want to say a few things about our healthcare coalitions. I know many of you are already partners in the healthcare coalitions. Our healthcare coalitions are a regional network within our state of groups of healthcare providers and other folks related to healthcare who have established a healthcare system approach for preparing for, responding to, and recovering from incidents. We are planning workshops beginning in 2017 that involve our healthcare coalitions in responses to diseases like this. You facilities, many of you are already part of them, but if you're watching today and your facility is not involved in your local healthcare coalition, we would certainly encourage you to do that. It's a tremendous way to get to know the other folks in your area and your region that have similar interests such as yours, and they're very important in terms of our communities being prepared for and responding to and recovering from some type of incident that may involve you. The Healthcare Coalition serves as a multi-agency coordinating group to assist with preparedness, response, recovery, and mitigation. And so we would certainly want you to be involved with that if you could. I'll show you here. Finally, I'll say Healthcare Coalition serves as an excellent resource for planning within your community as it exists as a collaborative network of healthcare organizations and their respective public and private sector response partners. Healthcare coalitions provide you with the opportunity to plan, to do exercises, to evaluate response plans. They will help you to be better prepared to respond to any serious infectious disease or any other public health threat or emergency or natural disaster or similar things that may affect your community. I'll show you our current Healthcare Coalition map. As you can see, these are correlated with our current public health areas and are located in these regions here. As of October 1st, because of a realignment, we're going to go to a slightly different map, and we'll have a different public health regions that I'll show you here, effective October 1st. And that's really all the information we have for you today. We appreciate you joining us today, and we hope that this has been helpful to you and helped to explain the evolution of the SID network, the importance to it of our society, and how each person fits into that. We're certainly happy to answer questions at this time. If anyone has questions, we'll address them. Thank you for joining us.
We do have one question. How much PPE should frontline hospitals keep on hand for these type of patients?
Would you like to do it?
Sure. So according to the CDC, all hospitals don't have to have the same amount of PPE. And certainly, you know, we understand budgets are tight. And when you're thinking about purchasing PPE and something that might stay on the shelf for a while, hospitals don't want to keep extra. You know, you want to have just the right amount. Definitely, we want frontline facilities to have enough PPE on hand for 12 to 24 hours of care for their patient. So that's really kind of the goal that we've set in mind. If you can have more, that's wonderful. But we think that benchmark of 12 to 24 hours worth of PPE for frontline healthcare facilities. Now, how much that is depends on exactly your PPE strategy for your hospital and how much you're going to use and how many providers you have. But 12 to 24 hours is that benchmark that we've set for frontline facilities.
Great. Thank you.
So if they're not a hospital, they're still a frontline facility but not a hospital, and they have someone that they suspect has a serious infectious disease, must they immediately call the ADPH, or can they transfer them to another hospital and have them call ADPH?
So definitely, if a frontline facility that's not a hospital has a patient that they suspect may have Ebola or some other serious infectious disease, I know certainly when you have another emergency at one of these facilities, your typical response is to go ahead and have those patients transferred to the emergency department directly. Now, with these types of diseases, this is a little bit different, and this is a change from our normal practice pattern. And what we would ask is that you do go ahead and notify ADPH immediately so that ADPH can help guide the next steps for the care of this patient because of the public health implications of accidentally spreading this disease around. So we do ask that you deviate from your normal practice patterns with these patients and involve ADPH early prior to moving those patients so that we can make sure we do it as safely as possible.
Mm-hmm.
The final question I have before we open it to questions in the room is, are there any future plans or exercises to consider diseases other than Ebola?
Yeah, I'll take that. Yes, there certainly are. As part of standing up this network, our assessment hospitals all were required to prepare for and conduct an Ebola scenario exercise. And in fact, the most recent one was done yesterday. Those hospitals have completed that, and so now that this has been done, they'll continue with planning for things that may come in the future. We'll have annual exercise scenarios for them, at least annual exercise scenarios, depending on what diseases are identified, which ones are pertinent, which ones they may want to consider. Additionally, as I mentioned earlier, ADPH will plan to conduct healthcare coalition workshops, which will again sort of work within this, understanding this tiered response and operating within this tiered response of the SID network. And they'll be starting those beginning this fall and continuing into next year as well.
We actually have a phone call question from Jefferson County. Excuse me. Go ahead, caller. Seems we may have lost our phone caller from Jefferson County. Don't forget, you can call or email your questions right now if you have any questions that we can answer. Does anyone in the room have any questions?
Yes, I have a question. I understand that in putting this process together, it's taken some time to do that. Could you give us some idea of how long and who was involved in the process?
It actually, it took several months for each hospital. Oh, you're talking about it for assessment centers in particular, or
yes?
Yeah, right. So for assessment centers, it was a course of several months. It involved many different folks from many different areas. In meeting with the hospitals, there's so many different aspects of care that have to be gone through, and it's not only providing clinical care for the patient, but infection control issues as well. It has to be proper notification. There has to be coordination with EMS, but also coordination with municipal folks as well. There has to be plans in place for waste management, as we discussed, and each one of these institutions sort of has their own unique relationships with the folks in their community. So it was truly multidisciplinary and just required folks from all across the spectrum to do. It's a tremendous amount of work that they did, and again, I certainly want to congratulate them for being willing to do that and going through that effort to stand those up.
We have an email question. Where can we find protocols for sterilizing isolation rooms where a patient was kept frontline?
That's hospital.
Yeah, I think that information is available on the CDC sites that I showed you earlier. They include ways of handling waste, but also of doing proper infection control, and that link was available within the presentation.
And we may have the caller from Jefferson County back online, but I'm not sure. Caller, if you can hear us, will you go ahead? It appears we don't have them.
I have an additional question, and it concerns transportation from the assessment facility to the treatment facility. Once a person has been identified as being confirmed to be positive with either Ebola or one of the other serious infectious diseases, how will this occur?
So that's a great question. So ADPH has contracted with the EMS provider for that transportation piece if we do have a confirmed patient. So we do have an EMS provider on contract for those transports for patients who have confirmed cases of Ebola. And we are part of a regional plan with FEMA. And so as part of that plan, if everything goes as planned, we have contracts with air transport providers. And so we, with this EMS provider, would pick up the patient at the assessment facility, transport them by ground to a regional airport, and then the patient would be picked up and flown to Emory to our regional treatment center.
Thank you.
Do we have any more questions in the room?
You know, I'd just like to say, Dr. Harris, before we before we are finished, I'd just like to echo your comments about the healthcare coalitions. You know, I've heard feedback from a lot of our partners across the state just how vitally important their participation in the healthcare coalitions has been. They found it very useful, not only with useful information and relationships that they've built, but it's also been very useful for them meeting requirements for Joint Commission and other regulatory bodies. So I'd like to encourage everyone, if you haven't participated in Healthcare Coalition, you might want to look into it because they have been very helpful for a lot of folks that we've worked with.
That's a great point, and I appreciate you reiterating that. Just in my area where I've been involved with healthcare coalitions, even though there are requirements in many cases and so on, the real benefit of that is just getting to know the folks in your community who care about the same things that you care about, and they are interested in the health and safety of their community. And so you find people with common interests, you find people that have unique resources, and as you know, people have unfortunately learned a disaster is not the time to try to be making those relationships and trying to figure out who does what and how to get it done. So it's really true. The healthcare coalitions are just a great way to form those relationships and know where resources can be available, and it's just the best thing for your community. And I want to echo that, to encourage people to get involved in that.
Absolutely.
Thank you very much for being involved in our program today. This concludes today's program. We appreciate the presenters sharing their knowledge with us, and we appreciate each of you watching. Have a great afternoon.